Welcome back to Optimizing the Management of Patients with Epilepsy, presented by the Penn State College of Medicine at NeuroSeries Live. You are tuned in to today's final session titled Approaches to the Management of Patients with Refractory Epilepsy with Dr. Andrew Cole. My name is Dr. Lawrence Hirsch, and I'm Professor of Neurology at Yale School of Medicine. I'm pleased to serve as Activity Director for this important educational program. For those of you just joining us, today's session is a live interactive program that allows us to take questions in real time throughout this presentation. I encourage you to send us your questions anytime by typing them in the box located at the lower left-hand side of your screen. I'd now like to introduce today's second presenter, Dr. Andrew Cole, Professor of Neurology at Harvard Medical School and Director of the Epilepsy Service at Massachusetts General Hospital. Andy, thank you for joining us today.
Hi, Larry. Thanks for having me.
All right, let's get started. Start just very briefly. Let's assume we have a young adult woman with refractory focal seizures, failed a couple of medications already. So how common is epilepsy, and specifically refractory epilepsy?
Well, as you know, the prevalence of epilepsy is about 1% in the population, just under 1%. Of those patients, about 2/3 have focal epilepsy and 1/3 have generalized epilepsies. Of the focal epilepsy patients, about 1/3 of them are drug-resistant or refractory. So that boils down to about 0.2% or 0.3% of the population. We're going to talk a little bit later about the utility of anticonvulsant drugs in that population. Of course, there are refractory patients with generalized epilepsy also. So refractory epilepsy is a common problem. In fact, overall, you might say that as many as 30 or 40% of patients with epilepsy have refractory epilepsy. Those are the facts. And even patients who respond to epilepsy often have significant toxicities from their treatments and their medications. The other important point is that when patients have epilepsy that's ongoing, the duration of the disease, the exposure to the disease, is long. It's often over the course of a lifetime. So this is really a big problem, and it creates a large unmet need for patients.
Okay, and can you talk a little bit about the dangers of refractory epilepsy, and are there harms to having chronic seizures or not?
Well, absolutely. Here's a list of some of the consequences of refractory epilepsy. In fact, it comes from a paper that you were a co-author on that was just published in Epilepsy and Behavior, written by Ken Laxer and a large group of people who study this issue. You can really break them down into mortality risk, as shown on the graph. Fairly high mortality rate, certainly an increased rate over the standardized mortality ratio in patients with epilepsy, whether it's idiopathic or symptomatic. They have medical comorbidities, osteoporosis, for example. They have psychiatric comorbidities, high rates of depression and anxiety. Patients with epilepsy clearly suffer progressive neurocognitive decline over time with memory difficulties. There's social stigma and dislocation, underemployment, unemployment. These patients utilize tremendous amounts of healthcare resources, the dollar value of which goes up exponentially with the number of seizures per year. And finally, patients suffer chronic treatment adverse effects, toxicities, cognitive dulling, sleepiness, weight change, things of this nature. So the consequences of refractory epilepsy are profound for individuals.
Okay, I do think that's something important to keep in mind when you're talking about the risks of any interventions, and something that's It's often assumed there's no risk to doing nothing, but there's obviously a significant risk to doing nothing for these patients. So when do you consider epilepsy refractory, and what are the main options for these people?
Well, the first issue is defining what we mean by intractable or refractory. And a lawyer might define it as shown on the slide, that the epilepsy is uncontrolled after an adequate trial of available drugs singly and in combination. But there are a lot of words in there that are hard to define. What do you mean by an adequate trial? What do you mean by a combination? Is that 2 drugs, 3 drugs, 4 drugs? Etc. So a practical operating definition that we use, an operational definition, is if after 1 or 2 years of working closely with a qualified neurologist, a patient's seizures remain uncontrolled, for all intents and purposes, that patient's epilepsy can be considered medically refractory. Some people say you should have at least documented failing in trials of 2 or maybe 3 standard medications. That's an alternative criteria. Typically, that's occurred within 2 years of care with a neurologist.
Okay. Let's When people come to you as having refractory epilepsy, how often is that diagnosis inaccurate?
Well, it's inaccurate some of the time, and there's a list of reasons, what we call correctable reasons for refractory seizures. Perhaps the most common is incorrect diagnosis, and that's generally a physician error. Inappropriate treatment is occasionally the case, and I'll give you an example of that in just a second. And inadequate treatment, and that can be either the physician's fault, inadequate dosing, wrong choice of medicines, not enough medicine, or it can be a patient problem. It can be a compliance problem. It can be a lifestyle issue, things of that nature. Here's a case for you. This is a real case that I saw a number of years ago. A lovely 65-year-old lady from the Cape who came in. She had a history of seizures as a youngster with some daydreaming episodes, and she'd been treated with phenobarbital and Dilantin as an adult for a number of years. But recently she developed a new kind of spell. She would have days, her daughter would describe, where she would become progressively withdrawn, quiet, sit on the couch, non-interactive with her family, and this could go on for as long as 24 hours, and it would invariably end with a generalized convulsion. So her physician treated her with carbamazepine, and every time she had one of these generalized convulsions, he increased the dose of carbamazepine, and the frequency of these episodes increased. What was key in her case, of course, is that when we looked at her electroencephalogram, it was clear that she had generalized spike and wave discharges, somewhat fragmented, as we often see in an elderly individual or an older individual, but nonetheless, clearly a generalized problem. And the point of the story was that carbamazepine is really contraindicated in some patients with generalized epilepsies. It can actually worsen the idiopathic generalized epilepsy syndromes. So she was switched to Depakote, and she lived happily ever after without any more seizures. So here's an example of both the value of making a specific diagnosis using our tools like the EEG, sometimes continuous EEG, which we can talk about in a minute, and the importance of getting the diagnosis right and not using a drug that exacerbates it. This is a physician error. So this is one example.
Great. So it's important to get the syndrome right and to make sure that it is epileptic seizures you're dealing with. And I assume the best way to do that is to bring people into the epilepsy monitoring unit for video EEG monitoring. So do we have any literature on how effective those are? How often is it successful? And just comments on using epilepsy monitoring units.
Yeah, you know, there are a lot of ways you can do EEG. So you can do EEG in the laboratory as an outpatient. You can do long EEGs in the laboratory, 2, 3, 4 hours. You can do ambulatory EEG overnight or for 2 or 3 nights. And you can do inpatient video EEG. And each has its place, each has its advantages and disadvantages. Just to pause for 1 second, there are really 2 reasons for trying to capture seizures. One is to understand whether indeed they're epileptic, and if so, what kind of epilepsy. And the other, which is a secondary reason, is sometimes to localize the epilepsy from the perspective of considering surgical treatment or something of that nature. You know, if you think about ambulatory EEG, the patients are at home. They like that. It's a little bit less invasive or intrusive. Some patients seem to have more of their typical spells in the home situation than they do when they come into the hospital. But if you think of the advantages of inpatient EEG, we have the opportunity to directly observe these patients with simultaneous video, with nurses and technologists who can interact with them at the time of their spells, as well as throughout the day, and understand what other issues might be happening for these individuals. For some patients, remarkably, when they come in the hospital, it's less stressful than being at home. And sometimes we see patients whose seizures seem to stop when they're in the hospital. So that's sometimes a source of frustration, but usually we have ways of making the hospital stressful enough for our patients. There are some studies. This is a nice paper from Australia that looked at the utility of video EEG monitoring as a function of the epilepsy syndrome. And if you notice, there are significant changes in the right-hand column in the diagnosis after video EEG monitoring. Notice the bottom line, the bottom row of this. In patients who ended up having non-epileptic attacks, there was a 30% increase in the recognition of non-epileptic seizures after video EEG monitoring. And actually, this speaks to an important point. We talk about intractable epilepsy, but we have patients with intractable non-epileptic seizures as well. The average time to diagnosis of non-epileptic seizures in the United States is about 9 years. 9 years of treatment with anticonvulsant drugs, label of epilepsy, without addressing the fundamental underlying issues. So video EEG monitoring can really crack that wide open, so to speak.
That's a great point. I think that's also true, and it's not because it's underserved or unavailable, but we see that in the New York and Boston areas too, where there's plenty of availability. So
Oh, yeah.
just a matter of